Good afternoon, everyone. Really pleasure to have you all here. So glad you could join us. Those of you who are here live with us, thank you so much. For those of you who are watching at home in your time, in your leisure, in your off hours, we thank you for that too. My name is Deb Stein. I am here on behalf of the American Board of Surgery, Trauma, Burn, Surgical Critical Care Board with my very good friends, Amy Hildreth. Amy is the chair of surgery at Prisma Health at the University of South Carolina in Columbia, South Carolina, and my friend Krista Copps, who is at the University of California, Fresno. And we are here on behalf of, in our roles as the leads for the Entrustable Professional Activities Project for the Surgical Critical Care Board of the American Board of Surgery. And so that's what we're here to talk to you about today. So just real quick, because I'm an over discloser, these are our disclosures, none of which are relevant to our discussion today, other than we are here again on behalf of the American Board of Surgery and the Trauma, Burn, and Surgical Critical Care Board. So I'll turn this over to Amy for the first part of our presentation, and then I'll take over from there, and then Krista will finish us out, and hopefully we'll have some time for some questions if anybody has any. So I look forward to it. Thank you so much.
Thanks, Deb, and welcome to all of you. And I'm excited to be here today talking to you about surgical critical care EPAs. But first, we're going to talk a little bit about EPAs in general and a little bit about the general surgery EPA rollout, because I think it's relevant to understanding, even though I realize probably most of you have some experience with general surgery EPAs already. So what are EPAs? Really, EPAs are a new assessment tool to really advance the way that we look at performance in both surgery residencies and also our fellowship programs, as we're talking about today. So why did we need a new assessment tool? So you look at the current system, really it's focused on an amount of time in training. And obviously we have metrics that our trainees have to meet during that amount of time. But really it's just, a year for a surgical critical care fellowship. And you can see that in a year or whatever fixed time of your fellowship training program, that it's possible to have a variable outcome. So you have trainees that go through the program and actually hit wildly different levels of competency by the end, because it's really based on the time and number of weeks on a certain rotation, et cetera. What we would like instead, next slide, Deb, please, is a system where instead we look at the end goal being the competency, the skills, the abilities of our trainees at the end. And so we really want to get a fixed outcome. We want, not to call our trainees a product, but we want the finished product that looks relatively similar. And as you can see on this slide, it may sort of take a different path for each of those three trainees on this slide to get to that fixed outcome. And so you can hit the next button, Deb, and sort of show what that looks like. Yeah, so you can see everybody traveled a different path, but got to the same place at the same time, at a different path, same outcome. And so traditionally, how have we evaluated physician competencies? We'll talk a little bit about the history in a moment, but you're all familiar with the ACGME competencies that we have both for our general surgery residents and also all of our fellowships. And some of these are relatively easy to assess. When you look at the competencies of medical knowledge and patient care, you can see there's a smiley face there on the slide, and they're in green because we all really know how to assess those. When you look at someone's medical knowledge, you can ask them questions on rounds. If you want to assess their patient care, you look at their actions when they care for a patient. It gets a little bit cloudier when you get into some of the other core competencies, like, for instance, interpersonal communication skills, professionalism. A little bit of that is I know it when I see it, but you can't really describe what you're looking for when you assess those competencies. And then we get on to, for instance, systems-based practice and practice-based learning and improvement. Any of you who've either tried to assess a resident or a fellow on these, or sit in a clinical competency committee and try to assign someone a rating on these, that it's very difficult and very subjective and really difficult to nail down what these mean. That's why they're in red and there's a sort of silly face, because I think they're really hard to assess. Next slide. And so you can see here, for example, patient care 1, an ACGME milestone. These are for general surgery, but you can see that the descriptors for patient care 1 are fairly straightforward. You develops a plan to manage healthy patients with straightforward conditions, for example, colon cancer or breast cancer. But what if, for instance, the resident does, or the fellow does great with colon cancer, but not as well at breast cancer? Where do you put them in their milestone for patient care? Likewise, systems-based practice 3, physician role in healthcare systems. Level 3, sort of in the middle of the road, analyzes how personal practice affects the system and describes basic elements needed to transition to practice. And so nowhere in just the natural caring for patients is there an easy way to assess any of these items that are described in level 3 and systems-based practice 3. And so, while this was the best thing that we had, we certainly need something new. Can advance, Deb. And again, patient care 1, you want to see that the resident or fellow can diagnose many core conditions and can initiate some management, or at level 3 can diagnose and manage most core conditions. But that requires that you, as an evaluator, remember what are the core conditions, and what is some and what is most. So EPAs really represent a way to, instead of trying to do this global assessment of each of these milestones individually, to really look at how we actually assess trainees when we go through our days. And so to sort of have more of a holistic view that combines all of these competencies together in a single assessment, next click, Deb, of whether or not we would trust this learner to perform a given task without supervision. And so, this is something that we do naturally in our day-to-day practice, but we haven't really had a tool yet to help us do this in a structured way. So on the next slide, you'll see sort of the history of competency-based medical education and how all of this came to pass. And you can see, when you look at the milestones, and back this whole outcomes project to look at competency-based ways to assess residents and fellows came about sort of after the work hour restrictions, or right around the time of the work hour restrictions. So in 1999, the ACGME and the ABMS, the American Board of Medical Specialties, which is the big sort of umbrella organization that the American Board of Surgery sits under, adopted core competencies. And then in 2002 to 2008, which oddly it happens to be the time period of my residency, the residencies incorporated those competencies into their curricula. And then the American Board of Surgery and the ACGME published the surgery milestones. And then in 2013, we all started reporting this milestone data to the ACGME. But I think, even though we've been doing it for 10 years, it's still a point of frustration for us. And so concurrently, the EPAs started to be defined back in the early 2000s. And so EPA is basically an entrustable professional activity, and it basically is just a unit of work that can be directly observable and is related to the tasks that we do every day. This was developed by a guy named Tinkade, who's, I believe, Scandinavian, from the Netherlands, and then sort of began to spread throughout the world and really to the United States. Next click, Deb. Pediatrics was the first specialty to publish EPAs in 2015. And then in 2018, there's a pilot study of EPAs for general surgery that was actually really successful, despite the last sort of portion of it being in the middle of the COVID pandemic. Next slide. So again, EPAs, it's just an essential task of a discipline, and it doesn't necessarily, like EPAs exist for things other than medicine or surgery, but it's an essential task of a discipline that an individual can be trusted to perform independently in a given context. And so it's an activity related to a very specific task that an individual that you're training would do. And together, EPAs form the mass of critical elements that define a specialty. And it really shifts our assessment focus from the abstract and independent competencies to the work that must be done. Importantly, though, EPAs are the floor of what we expect our trainees to do, and really not the ceiling. As you'll see on the next slide, we, in general surgery, there are EPAs for many things that a general surgeon would commonly see or do, but not for all things we would expect our trainees to do. And so it's important to note that that a set of EPAs really defines you must do this in order to complete training in this specialty. But really, that's the floor, and the curriculum is the ceiling. So all of the things that we expect a trainee to know at the end, all of the things we expect them to answer correctly on their exam, all of the things we would aspirationally like for them to know when they leave us. And so this actually works pretty well because we already do this. So you can see this surgeon standing at the scrub sink and you're thinking, I can let the resident start and scrub in for the key portion. You probably did an operation today where you thought about what portion you were going to let the resident do independently. Maybe it's a chief resident and you thought you'd let him do the whole thing. Maybe it's an intern and you thought you would be in the room with them the entire time and maybe let them do little pieces of the procedure. The problem with the way that we already did this is that it was all in our heads. It was not well documented, and we all did it in different ways. So if Deb and I had the same resident or fellow doing a given procedure, she and I might think about this in a different way for each trainee and not really have a common way to communicate it. And so one of the things that EPAs do is that they give us a common language and standardized behavior descriptions. And so, when you look at an EPA, there are 4 levels of entrustment from basically all the way from limited participation, meaning that your role in the case is very limited, to practice ready. And so that really, and then there are discrete behavior anchors that we'll go into a little bit more later that tell you exactly, based on the resident's performance, what their level of entrustment at the next observation might be. So general surgery EPAs, if you look at, they're available on the ABS website, and certainly if you haven't been exposed to them, I would recommend to you that you look at the general surgery EPAs on the website, because it'll give you an idea of the types of things that we consider to be the core skills of a general surgeon. So they're common conditions. Each of the EPAs includes other essential non-technical skills, but those aren't listed out separately as EPAs. The EPAs all relate to a specific patient that one would see. So trauma, gallbladder disease, inguinal hernia, right lower quadrant pain, and then there's one for just surgical consultation. Next slide. So you can see here there are 18 total EPAs for general surgery, and you can see here in this nice graphic sort of the organ systems and the types of patients that are involved in those. You can see that, of interest to us in surgical critical care, that there are probably surgical consultation, trauma, and critically ill patient, which are all very closely related to what we do, in addition to, all of the other disease processes that we take care of there. But what's important about the surgical critical care EPAs is that we are going to build on the skills that are expected in these areas for general surgery residencies, and really nail down what the core skills are for surgical critical care fellows in these areas. Next slide. The general surgery pilot, as I mentioned, was very successful. There were over 1,000 residents that participated in this for over 6,000 observations, and an average of 5.6 observations per resident. Residents who received at least one observation had a mean of 7.25 observations, meaning that basically there are probably some people who just didn't participate at all, but that for those who did, they got about 7 independent observations. Next slide. And interestingly, for us, I think, is that the source of the observations is really only 85% surgical faculty. So non-surgical faculty in the pilot participated in 13.8% of the observations, which is kind of cool for us because we have fellows that rotate in a variety of different areas, and perhaps in some specialties where there aren't surgeon faculty observers. Perhaps they're rotating in the MICU, and or perhaps they're rotating in the CT surgery ICU, and there aren't surgical faculty in that area. So it's important for us to know that a pilot can be, that in the pilot it was successful to have non-surgical faculty assessing as well. Next slide. And participation obviously is highly dependent on program engagement. You can see here the sort of graph of microassessments that were done at University of Wisconsin, actually. And this is a place where they were very successful because they had a very engaged chair and program director. I think you probably, many of you will recognize Dr. Mentor, the chair on the left, and Dr. Greenberg, their program director on the right. But you can also see that that there's some time points during the year where they saw some spikes in participation, around the CCC meetings, the new resident academic year, so this slide is just there to say that there's going to be some variability in participation in any program over time, but that leadership engagement is very important, and frequent touch points to really drum up support for this method of assessment. Next slide. So the general surgery EPAs and surgical critical care EPAs, this will also be true, but there are 3 phases. They look a little bit different in our EPAs, which I think Krista or Deb will talk about in a moment. But general surgery EPAs have a pre and intraoperative and a postoperative phase. And you can see this is just some initial data about numbers of assessments by phase and by EPA. And you can see that there are vastly more assessments in the intraoperative phase for the general surgery EPAs. And so that will be one challenge that I think we'll discuss a little bit later about surgical critical care EPAs, in that because our board designation really allows for people who, non-surgical trainees who don't do operations to go through our programs, that really we have to be able to observe everything that we list in an EPA. There's not going to be much intraoperative assessment for us. And so our phases look a little bit different, and we may have to work a little bit harder to make sort of the workflow natural to get those assessments done. Next slide. The EPAs in general surgery all are mapped to the ACGME milestones. You can see here that really only professionalism 3 was not represented among all the general surgery EPAs, which is the you answer your emails, you sign your charts sort of professionalism milestone. And this is nice because even though this is an additional thing that we're asking programs to do, it will eventually feed into the assessment that you already have to do. And so CCCs can use this pre-population, this mapping to populate the ACGME milestones. When you look at sort of in the background how the EPAs are constructed, each behavior relates to an ACGME milestone and has a level assigned for a given ACGME milestone. So when you do your EPAs, you don't have to think about the milestones, it's all in the background, but they map directly to a milestone. And so when you do an EPA, there will be milestones mapped directly to that and assigned. So you can see sort of on the right hand of the screen what it will look like when you look at this sample resident here who got an indirect supervision in the pre-op, an direct supervision in the intra-op, and indirect supervision in the post-operative, what their milestone levels will look like. And the idea is that there are frequent micro assessments, and so you get lots and lots of assessments that feed into this milestone discussion. Next slide. And this will be what the dashboard will ultimately look like for your clinical competency committee, where you'll get, based on the EPAs that have been completed, an estimated milestone level for each of these designations. And then you'll also see off to the side the number of assessments and then the number of independent assessors, and that can help inform the CCC decisions and reviews. All right, and now we'll move on to surgical critical care EPAs, specifically the development and some of the unique challenges and some of the unique opportunities we have in surgical critical care. So I'll move on to Deb next. Thanks.
Great. Thank you, Amy. So for those of you, I don't know that we actually said this up front, which we probably should have, is that this is coming to surgical critical care fellowship programs in the upcoming academic year. And I just want to kind of walk you through what we have been very busy doing over the past 2 years now, working on behind the scenes to get us to this point where we are right now. And then we'll turn it over to Krista to talk about some of, as Amy pointed out, the unique challenges about surgical critical care fellowship training as opposed to general surgery training. So here you can see that this has been a labor of love for myself, Amy, Krista Copson. We've been working with Karen Brassel extremely closely on this. She was instrumental in implementing both the pilot as well as the full rollout of the general surgery EPAs, actually initially through her role just as a counselor in the American Board of Surgery, and now through her role as the vice president of the American Board of Surgery. We defined a scope council, which I'll talk about a little bit, which is which the Trauma Burn Surgical Critical Care Board served as the scope council for this project. We conceptualized and refined topics and defined scope for each. We created it or assembled a reactor panel, which we'll talk about a little bit, and then a writing group of 28 extremely hardworking members who are a huge amount of fun to work with. So there were a couple of things when we embarked on this project in 2022. There were a couple of things that were kind of unique to surgical critical care fellowship training that's different than any other component board of the American Board of Surgery, including general surgery. One is we're the only one-year fellowship. So Krista will touch on this a little bit about the challenges that presents when we talk about number of assessments and using those assessments to actually define competency. We train non-operative, non-surgeons. So we have emergency medicine providers who sit for our boards. So we had to make sure that our EPAs were relevant for those individuals, because every EPA has to be able to be used by every fellow on every fellowship. We have non-general surgeons who do our fellowships. We have OBGYNs, neurosurgeons, et cetera, et cetera. We have people who are board eligible who sit for our board certification exam who do non-surgical critical care fellowships. And so we had to think about, if they don't have EPAs and assessments, how can we hold them to the same standard? And then we have a variety of fellowships that are really subspecialized. We have pediatric critical care fellowships that don't do any adults. We have adult critical care fellowships that don't do any peds. And we have burn critical care fellowships where they really focus on burn and not so much on some of the other things in some of our non-burn critical care fellowships. And then we also have people where they have not completed their general surgery training, i.e. the PGY3s, that are eligible to do our fellowships. And how do we kind of think about what their assessments are going to look like when compared with somebody who's already completed an entire general surgery residency? So all things to keep in mind as we kind of constructed our EPAs. This is a little bit of how the sausage gets made, so I apologize. And I will not harp on this too much, but these are the actual steps to how you create EPAs overall. And what we did was very similar, kind of modeled entirely off of what general surgery had done. And the other board that was ahead of us in this was vascular surgery. And then we were working kind of concurrently with the pediatric surgery board as well as the complex surgical oncology board. But you'll see here, these are the 11 steps to creating an EPA, kind of a little bit like for those of you who remember Schoolhouse Rock is how a bill becomes a law. And I'll walk you through that a little bit. So the selection of EPAs, the Trauma Burn Surgical Critical Care Board brainstormed all likely candidate topics for EPAs. And I think we wound up coming up with close to 50 or so overall just general topics, which we then lumped into 29 topics for possible inclusion. We then did a modified Delphi process where we ranked the topics. Each of us ranked the topics. I think there were 13 board members at that time. Each of us ranked the topics on a scale of 1 to 4, 4 being this topic absolutely must be included in our EPA suite. 1, this topic should absolutely never be included in our EPA suite. And then you can see what 2 and 3 are kind of modified Likert scale there. And we wound up, this is the final list of EPAs that are almost finalized now. And you can see here that we have 9 core EPAs. These are the things that every single one of our fellows who's going to sit for our board certification exam should be able to be evaluated on. And then 4 optional EPAs to help account for some of those special populations, those unique fellowships that don't do the broad breadth of surgical critical care, like our pediatric, our burn. We have a geriatric one or critically ill older adult for those programs that do a lot of geriatric care, and then one for patients who require extracorporeal lung support. But the 9 core is the expectation that all of our fellowships will evaluate all of our fellows on each of these, using each of these 9 EPAs. And then if the fellowships can then choose the additional or optional EPAs if they would like. We then recruited the reactor panel and writing group. We did this pretty broadly. Many of you probably saw our solicitation. It went out in the broad surgical critical care community to our societies, as well as other organizations representing our other stakeholders like anesthesia and pediatric surgery. We really tried very hard. Amy spent a ton of time and energy making sure that we had appropriate diversity with respect to type of practice and geography and race and gender and all the things that we wanted to make sure that we really had broad representation, as well as with respect to years from training. So we really wanted to make sure that we had a broad breadth of people who we had a couple of fellows who were on our writing, who've been on our writing group, who've been amazing. And we have a couple of gray haired people like us who've also been equally engaged. That's been really wonderful. 97 unique names, 15 individuals selected for the reactor panel, 29 for the writing group. This is the writing group, amazing, amazing group of people. Thank you, thank you, thank you. If any of you are out there, if any of you know these people, I can't tell you how much fun and how dedicated and hardworking this group is. This is a huge amount of work. And I really we all three of us just are so grateful to all of these individuals who put their time and who have continued to put their time and energy. You guys aren't done yet if you're out there, so almost, but really just a huge amount of work and energy and effort. So thank you to you all. This is our reactor panel. These are the individuals who kind of react to the work product, and I'll walk through a little bit of what they did. And again, to these individuals, thank you for your time so far. I think we're on your schedule for next week. So looking forward to seeing you all to re-review some of the close to near final product that your writing group has been working on so hard. So you take these now list of 13 EPAs, 9 core and 4 optional. We then took our writing group, the 29 members were grouped into 13 dyads or triads, and each group is then tasked with writing the new EPA in a graduated fashion. The first task of the writing group was to draft descriptions of the 13 EPAs. You can see on the right-hand side there, that's what a description of an EPA looks like. This happens to be the hemorrhagic shock. These individuals then refine the inclusion, exclusion, and scope, which you can see listed down there below. And then our dyads and triads got intermingled, grouped further to review and critique each other's work, and then final approval from the overall group until we were happy that we had these 2 first steps, the description and then scope, inclusion, and exclusion for each of our 13 EPAs. We then took that information to the reactor panel. They threw things at us. They yelled at us. No, I'm just kidding. They gave us amazing, amazing feedback. Super helpful, thought of things we hadn't thought of, but really spent a huge amount of time with us, going through each of these 13 EPAs, the definitions we had come up with, the scope, the inclusion and exclusion, to really help us better define these before we got into the meat of the activity, which was actually writing the functions and the behaviors. One of the things we then had to do was decide about our phases of care, as Amy talked about in the general surgery EPA suite. It's preoperative, operative, and postoperative. That's obviously not relevant for us. So after much discussion, much heated discussion, and probably a couple of drinks at the bar that night when we all were in person in Philadelphia, and that may actually not be true, we came up with the 3 phases that we were going to use for actually all 13 of our EPAs. Is initial resuscitation. So that's the patient first hits your ICU, ongoing care, your day-to-day rounds, et cetera, and then transitions of care. They're then transitioned typically out of your ICU or potentially to transition to hospice or that type of thing. That's all included in that transitions of care phase of care. Then for each EPA, the dyads and triads created what we call a function. So these are the essential functions that we expect each of our learners to be able to do. And you will see here, these are the tasks. These are things like, and again, this is, I believe, the hemorrhagic shock one, evaluating volume status to determine the severity of shock. That would be considered a function. Utilizes evidence-based resuscitation strategies and achieves hemostasis. So again, these are the functions that then get crafted. That's the next step of development of an EPA. And then what we call the cognitive framework. So Amy talked about for the general surgery EPAs, limited participation, direct supervision, indirect supervision, and practice ready are what they're called. But we then needed to define what for surgical critical care that was going to mean. And so we did something that was a little bit different than what general surgery did by the nature of the diseases and the patients that we take care of, is that we actually incorporated the complexity of the patient into this framework. So direct supervision may be, hey, this resident is great with a simple basic patient. They don't need me there. But once we're starting to prone and start neuromuscular blockade and thinking about ECMO, I need to be there at the bedside with them. And so you can see how the severity of the patient illness got incorporated into our cognitive framework here with respect to that progression from limited participation, i.e. what you would expect, not necessarily whether they start out, but certainly what a resident might be able to do, all the way through to what we expect our faculty to be able to do without even thinking about it, which is being obviously practice ready. And then we did the same thing as was done with general surgery. We mapped the milestones. You will know, I'm sure most of you know, that the surgical critical care milestones are different than the general surgery milestones. So some of these map very naturally. You can see here the top line here, respiratory failure, for example, is PC1 for surgical critical care. Obviously that maps exactly to the respiratory failure EPA, but it also mapped to the burn EPA as well as to the extracorporeal lung support EPA. makes sense. You'll see here there are a few that have no mapping, and that's based on what Amy was talking about, things like patient safety and quality improvement. You can't assess that in a patient interaction, right? Those are things like, or provider well-being, those types of things you can't necessarily assess. So we have a couple of milestones that we were not able to map to any of our EPAs, but we did pretty well. I think there's only 3 of them that we were unable to map to any EPA. Then we get into the hard part, which is the writing, well, the really hard part, which is the writing of the behaviors. And you can see here again, this is hemorrhagic shock, and you can see that these are the behaviors that for each of those levels of entrustment, level 1, limited participation, all the way through to level 4, practice ready. And you can see for the initial resuscitation, ongoing management, and transition of care phase of care, there are behaviors here. So for example, accurately orchestrates initiation, implementation, and cessation of massive transfusion, which is then mapped to EPA patient care 3 and at a level 4, which will then, as Amy pointed out, directly drop into your milestones that you'll be able to use for your clinical competency committees. But these are the behaviors. Again, this is all draft, so please don't hold us to this. It's still not finalized yet. But this is what surgical critical care EPAs are going to look like. And again, this is the one that happens to be for bleeding hemorrhage control. We then are right now in the process of going back to our reactor panel with those behaviors. The reactor panel will be reviewing those. Again, we'll solicit feedback. We expect there'll be some modifications, but we really, again, want to lay as many eyes on this as we possibly can to make sure we get it right. And it will probably need some tweaking. I don't think any of us is under the delusion that it's perfect, even after the reactor panel lays eyes on it. So I expect this will be somewhat iterative, but we do want to make sure that we do have it before a broad audience and also to put some new eyes on it as well, because I think I can tell you, Amy, Krista, and I have looked at these way too many times at this point, as have our hardworking writing group. And I think putting some fresh eyes on this to get some additional perspective will be super helpful. We are also in the process of doing what we call harmonization, which is this horizontal integration and vertical integration to make sure that things flow correctly. So the milestones are all mapped correctly in each of the phases of care, and to make sure that there's vertical integration, horizontal integration, and then ultimately the behaviors and the final documents will go to a medical editor who will fix anything that we screwed up. So this is kind of the roadmap to EPA implementation that General Surgery laid out for their EPAs. We're somewhere around here-ish, so the end of the tunnel is near. We do expect that we hope to have this to our medical writer by hopefully by no later than March 1st, and then allow them to do their thing. And then Krista will talk a little bit more about this, but with respect to implementation, the American Board of Surgery has actually decided the simple app that many of us are using, the vascular surgery board, when they did their pilot, they did find that there was some difficulties, and so they're walking through different opportunities with respect to other vendors right now. And so we won't be going live August 1st, but there's every expectation that this will be going live sometime in the upcoming academic year for our surgical critical care fellows. I believe this is just an example. This is, I believe, the critically ill child. You can see here again, the description of the activity. The functions will all be listed out on the PDF documents that will be available online. And then this is this is their level 1, for example, for resuscitation, ongoing management, and transition of care for a child. So I will turn it over to my dear friend, Dr. Copps, to go through a little bit about implementation and some of the unique challenges and some of the unanswered questions. Krista, you're muted, of course. It's her first time on Zoom.
Let's try that now. After the hundreds of hours we've all spent on Zoom calls. And I think as we've had all these hours of calls, we know many of you well enough, you know us, I know my colleagues, that we all tend to be sort of direct in our communication. And so the last thing we want, at least I want, is to have one of my colleagues come up to me after these things get started and say, "What were you thinking? These are absolutely unusable." So we've been keeping that in mind for all of you. Yeah, EPAs, again, I'm always very skeptical of the flavor of the month evaluation tool, or what's the fad this year. I think the important thing to think about is this isn't a fad thing. These are micro assessments to really help us assess provide a great assessment of our trainees. And the goal is not to add on something, but to make everyone's lives a little bit easier as we're trying to determine. So as Deb already alluded to, we anticipate implementation. August 1st had been the start date, but again, because of some technical issues, I think, as I understand it, from vascular surgery, when they tried to input fellows and use the same app, um, trying to keep general surgery residents and vascular fellows separated, it just kind of overloaded the system. So more to come. It'll happen. Data use agreements will happen first. I put the slide in simplest, and programs already using simple. Probably won't be the simple app, but it'll be something that is pretty user friendly. Remember, those evaluations go quickly. What's next? Implementation. It's education and awareness. We're kind of out, you know, putting trailers on Netflix now, and or wherever you would like. But we want to make sure that the program directors, and again, critical care programs are based where there are general surgery programs. So I would hope, sincerely hope, that the vast majority are already aware, but just so you know, it's coming. But the also is disseminating that to our critical care faculty. And as has been mentioned, not all of them are general surgeons. Some of them are pulmonary intensivists or medical intensivists or pediatric intensivists. We want to have our program coordinators involved. And as we often find out, our program coordinators are ahead of us. I had the opportunity to do a webinar for them a few weeks ago, and they're already envisioning, they're already asking about, you know, hey, are there going to be, is there going to be more information so they can disseminate it to the fellows? Deb, I believe you've got the controls. Is that right?
All right, yep.
All righty. So opportunities that we have are to do this right, to realize that this is to really be able to assess well the competency of our fellows and the ongoing activities. There was a survey that went in on the certifying exam, asking the fellows how they felt about their evaluations. Discussions in education. Let's go to the next slide. And I don't know, I've said this before, I don't know why we call them slides. Think of how long it's been since we actually had slides in a carousel. The next, so our best practices. Amy mentioned the pilot program that was at 28 general surgery programs. I've had several people have asked, well, are we going to have a pilot for critical care? It was talked about, it was decided, and at higher levels as well, as we said, you know, there are only 13 altogether EPAs. And in this sense, we're going to plan on full and fewer programs than there are for general surgery. We've had experience with general surgery. We're going to plan to unveil the whole thing. We're going to be looking for champions at each program, the people who understand and really encourage this. Remember that each EPA is the identification of a unique interaction. It's a single interaction. And as we've been writing these or helping to write these, that's one of the things we've gone back to time and again. Is this talking about a single period of time? We're not, you know, these assessments aren't for over a period of several days. This is, what did this fellow do at this moment regards to this? Next image, please. So the other part is, how does this help incorporate? And it's already been mentioned, and so I'm not going to beat on this too heavily. This was a picture from one of our in-person sessions, and we had post-it notes, and each group was mapping which milestones they were linked to. And you know, those of you who are critical care faculty, I know you all have your milestones memorized, tongue in cheek, but linking to those. And the beauty of having these micro assessments is that they can serve as an early warning tool. If we're starting to see assessments that are done in active time, that is, you know, as they are happening, if we're starting to see those, you can identify or help to identify the fellow who's maybe struggling a little bit or struggling a lot before you get halfway through the year, and help define areas of strength and opportunities for improvement. Again, as has been mentioned, we have an easier time evaluating knowledge and competence, but things like communication and professionalism aren't always as easy. And it's also the opportunity for the faculty to provide specific constructive feedback. We use MedHub for our evaluations here at the moment. And each month that I work with a fellow, I get sent a request for evaluation. As I was saying to one of my colleagues yesterday, I think my overdue MedHub evaluations, well, it's a little embarrassing to say, but I've got a whole bunch of them. And for me to go back several months later and fill out an assessment of my interactions with a fellow from October, unless it was something spectacularly awful or good, is going to be colored by my experience now. And frankly, it's going to be pretty vague and non-specific, needs to be more assertive. Well, that's just not very useful, or, needs to read more, equally unhelpful. So our goal is to have these micro assessments that are happening in real time. Next image. What are the risks and consequences? And I'm always really concerned about the unintended consequences. There are a few things that we've identified. So let's go to the next image. The evaluator bias. This is from an evaluation looking at evaluator biases. Do we talk about gender biases? This is, as you see, from EPAs in general surgery residents, and this is from initially when the initial assessments were collected in the pilot. I think you can all read as well as I can. You can see there were about half and half from faculty and residents. And it turns out that the faculty evaluations were not impacted by the resident sex, but what was found was that the female residents tended to rate themselves lower by nearly an entire postgraduate year compared to male residents. But it lets us have that ability to evaluate there. We don't have enough data yet to know about other instances of bias, but we do know in general that with evaluations, when you're trying to do global things, you carry memories of things that didn't go well with you. In this way, if you're doing an assessment of what is happening right now, the goal is that we're going to be better off and minimize our bias. Next image. So batch evaluations, and I was alluding to that. This is the time limited availability, at least in the current model. If a current resident asks me for an evaluation, it's there for a few days and then it disappears. If I want to go back, I can't go back and provide an evaluation from 3 months ago. And it eliminates evaluations from interactions that took place in the distant past or the murky past. Next image. And the institutional factors. Having 9 core and 4 optional EPAs lets each institution tailor the evaluations. As has been mentioned, when we started putting these together, we of course had geriatric patient as part of it. And our pediatric surgeon said, wait a second, our residents, our fellows will never see a geriatric patient. We said, well, what kind of fellowship is that? I said, pediatric, of course. Our fellows who are adult critical care fellows primarily, but do spend a month on the PICU. So we have the ability then to use that core or that, the optional EPA for that. Ditto thermal injury, our burn fellowships. And so the idea is to be able to use these things to really have the tools to assess. Next image. The things that keep us up at night, the concept of progressive engagement. When does the implementation happen? Nuts and bolts, how many EPAs, and how do they have to be at level 4 in every EPA? Let's next image. So how many EPAs does each trainee need to have? If we haven't mentioned it already, and I didn't quite hear it, if we get started on this pretty soon this year, our fellows will be the first ones completing to have had EPAs during their training, our 1-year fellowship, which is kind of cool. General surgery's got a few more years to go. So for the first year, what we have to demonstrate is that there's progressive engagement so that we are gathering more and more EPAs on each of our fellows. In the future, it's going to be a portfolio of evaluations that happens over time. What if the fellow isn't practice ready in all EPAs? What if they're at a level 3, they require some help in some of them? Is there a magic number? And the answer is, I'm not sure that we've got the answer to this yet. We're working this out. And the same is going to be true for general surgery as well. We're sorting this out, and it's something we have to see. But it's a valid question. Next image. And complexity. For critical care, we anticipate that many of these places will take place probably during ICU rounds and in the ED. But in a situation where you've got multiple patients with the same diagnosis, respiratory failure, without including patient data, how do we identify which evaluation and not duplicate that? And that's one of the things we're working out that needs to be worked out for our tools. Can you say these are time stamped as if you've used the apps now, but you may not do it right at that second. And so we have to figure out how we're going to determine, because somebody might be practice ready on one patient, but perhaps not on another. And so sorting all those technical details, and that's the management, and that's the exciting and challenging part of it. Next image. So the technical difficulties, separating residents from fellows in a system. And then the other part that we've talked about is all of you are aware that critical care is a 1-year fellowship. It's a condensed time frame. How many assessments do you need to have to be valid? And it's obviously, the answer is obviously not 10, but it's not going to be 3,000 either. How many do you have to have in each frame? And because of this condensed time frame, we want to have a reasonable amount throughout the entire period of time. Other challenges, awareness. It's always amazing to me that, well, and I've been on the other end of it too, but you're starting a new program, you start a new initiative in your ICU, and you've gone through education for your staff and for the residents and for the fellows and for your faculty and for the nurses. And inevitably, big rollout, lights, hoopla, dancing monkeys, whatever, there inevitably will be a person who's like, oh, are we doing something different? And you wonder, did we just crawl out from under a rock? What just happened here? So awareness, again, I think general surgery has paved the way for us. One of the things that, as I mentioned, is looking for champions at each place. The people, our coordinators are awesome and they help a lot, and they will be some of our champions, but we want some fellows who are going to be some of our champions as well. I think the writing group may all just roll over and disown us at the end of this. I don't know, but I'm looking forward to having some of them as our champions as well. We'll see. I don't know if they'll even speak to us. Deb, Amy, we may go to meetings and those people may just like duck and never talk to us again. I don't know what's going to happen. Next image, please. So unanswered questions, and there may be questions that we don't know. Do you have to be practice ready to sit for boards? And there is no data. This is new to lead in those conversations. And so research projects we're going to study this process as we go. And next image. And I think there's a little bit more on that slide. If you hit the click again. Yeah, thank you. Whoop.
Sorry.
No, it's all right. So thank you. We're also thanking all the people who've been our multiple content sources. And as has been mentioned, it has been my huge privilege to work with Drs. Hildreth and Stein on this. I don't know if any of us really quite understood how much was involved when we started. It's a good thing we started as friends, and we continue to, we've had the privilege of working together and working with awesome people.
Our bosses all want to know if we're getting an apartment together in Philadelphia.
Yes.
I think we have time for questions. I think I don't think we can do verbal questions, but if anyone has a question, I think there's a Q&A box where you can type something. We're happy to answer.
It always concerns me when people don't have questions. Either they've all either just all muted and they're like, working on their documentation on the side, and they're like, okay, phew, let's get this over with.
There's a kind comment from Dr. Nora, but anyone have, I don't know, anyone want to throw tomatoes or ask questions or?
I do think that this issue of how, for those of you who have been involved in the general surgery, who do a lot of general surgery EPAs, of identifying a given behavior or interaction that's patient specific. If you guys have any suggestions about what best practices you might suggest. So for example, we've done things like, okay, you're rounding in the ICU, and before you move off of a patient, you might quickly do the respiratory care EPA because we just took care of a patient with bad lungs, right? And then we've identified the patient, the fellow, and the behavior all together. But if there are best practices for how we could do this better, or people have suggestions, because it's really easy to identify the bad gallbladder you just did. Like that's like super straightforward. But we're really, that's to Krista's point about these are the things that keep us up at night. So any best practices, please send us suggestions. We'd like to be able to give people ideas.
We do have a couple of questions now. So anonymous attendee wants to know, will we still be doing MedHub evals while doing EPAs? Who wants to take that one? I mean, I guess, take out MedHub and insert, whatever program you use to do evals.
If somebody wants to do mine, that would be great. I do think because these are linked, the MedHub evaluations may be somewhat different. I think we're going to have to think about changing ours. And, part of it too is having been on our critical care CCC, it's 6 months we sit there, and I was the fellowship program director for a long time, but remain involved, is we would sit there and say, well, okay, this is a 1 to 5 point scale. Well, okay, that fellow's doing pretty well in this thing, on this milestone. So yeah, they're about a 3.5. Okay, well, or they could be 4. Oh, but maybe it's a 3.5. That way we can show them progressing to 4. I mean, it's an artificial, sometimes quite subjective. And so I do think this will let us really be more, have actual data to use. There will be some form of MedHub evaluations. I don't think it's going to entirely disappear.
Yeah, I mean, there are a couple of milestones that we were unable, that are not mapped, that we would still need to be evaluating on. Sorry, I didn't mean to interrupt you.
Oh, no, I think I interrupted you. There are general surgery programs that have significantly changed I mean, it is still an ACGME requirement to have an end of rotation evaluation, but there are some programs that have significantly changed their evaluation since the advent of EPAs, because they feel like that the EPAs serve an assessment purpose that is duplicative with the end of rotation evaluation. And so I think that there's some potential to change, to really subtract by adding when you add EPAs to your assessments. Let's see, I see there's another kind comment from Dr. Brazel, thanking us for the work that we've done. And I want to thank Dr. Brazel for her guidance. She's met with us, at least on a monthly basis, and some months much more. So definitely she's been an integral part of this work as well. Dr. Patel asks, with general surgery, we had great commitment early, but has faded. How do we keep people involved?
Yeah, it's a great question. I do think that the more we make this part of our daily workflow, the more it will remain a part of our daily workflow. But it's a great question. Probably I don't have a good answer for that. I wish I did.
I think one of the things that's been successful, at least in general surgery at my institution, has been sort of we've done a little bit of, competition, and surgeons love a little bit of healthy competition, and, to see who's on the leaderboard in terms of, numbers of EPAs completed and percent completed after a trainee sends you EPAs. But I think the other thing that's worked well is the fact that both faculty and trainees are engaged sort of in this bi-directional exchange of EPAs. And so sometimes the faculty will send it to the resident, sometimes vice versa. And I think, between the two parties, somebody gets it done. And I think that's been really helpful as well, that it's not just been one-sided, but agree. As with all evaluation tools, like you're going to have like your rock stars that like always do their homework. And then you're going to have some people on your faculty that are, like never going to do a single one. And I mean, it's that way with everything you use for an assessment. And obviously that we're going to have to struggle with that with EPAs as well.
There's been some discussion, I know, or at some of the general surgery programs, that people tend to have a carrot or a stick approach. And so some programs have taken, to Amy's point, like, friendly competition. I can't remember. I think it may have been Karen Brazel's program actually, where they had like a trophy, like a silly trophy that you got if you filled out the most DPAs that month or whatever it was. Other places have tied it to bonuses and kind of like your RVUs or your medical record documentation completion, and have tied the metrics to potential compensation and those types of things. And so I think each program will have to figure out what fits best for them. But we obviously we're looking for, to your point, I'd love for people to be excited early on, early adoption, and then obviously figuring out a way to sustain it with whatever works in your own environment, whatever works best for you all.
And I would also, I mean, everything that's already been said, but also there has to be support from department leadership, or program leadership, and yeah, incentivization. It's that, hey, let's all do this. And part of it too has been the goal of making these not painful. I mean, you can if something is onerous to do and takes time for busy people, it's not going to happen. So the goal is make this exactly part of almost automatic.
And just to clarify, because I've gotten an official opinion from our guru of all things milestone and EPA, that we're not getting rid of the milestones because they're required by the ACGME, but they will hopefully be shortened significantly by the use of this. And then again, the compilation of those milestones into competence, into formative evaluations that can then be used to trend your residents and fellows over time will be significantly aided by this. It'll hopefully be value added, as many programs have found it has been for dermal surgery.
Yeah.
Thanks, Karen.
And if I said that, I misspoke, because we do not anticipate milestones disappearing. It's just the act of having to try and sometimes artificially assign levels.
Any other questions? Thank you all for being here. Really appreciate it. If there are other things that come up, anybody has suggestions, thoughts, questions, comments, please, 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 I hope, please reach out to any one of the three of us. We would love to hear from you. And hopefully we will be able to get out information about when we do expect to go live shortly for everybody, but we do expect very much that it will be this coming academic year. So we'd like everybody to start thinking about how they're going to operationalize that now. And hopefully we'll have some best practices out to you all soon. So thank you to the AAST for allowing us to do this, for affording us this opportunity to get in front of this audience. Very much look forward to additional conversations and discussions about this. So thank you all so much.